We are here with Professor Vicente RIAMBAU, and thank you for your interview. And the first question I'd like to ask you is if there is, according to you, an endovascular treatment for an aortic pathology that we can consider mature nowadays. I mean, I've watched your interview of 2017, and what you said it was that actually endovascular treatment is nowadays not mature. But according to you, in some extent of the aorta, is there a type of treatment we can now, consider finished?
Not finished for sure, yeah. Okay. Unfortunately, not finished. Thank you for the interview, first of all. I think the endovascular approach for the arch itself, that was the topic this, is not mature enough because we have still some Achilles heel. That means you have some drawbacks. The most important one is the stroke rate, and the second one is how to deal with the endoleaks. I'm talking about not the immediate or early results. I'm talking about the long term. Durability is the concern in all endovascular approaches we are performing every day, because we know that the endovascular plus reintervention they run together. So I prefer to, at least in the next future, to avoid the second one. The second component is the reinterventions, but it still is a little bit far from now.
Okay, thanks for your answer.
Yeah.
And what I would like to ask you is, how do you manage at your center the choice between an endovascular first approach or a surgical first approach as far as aortic arch pathology is concerned? Do you have a cardiovascular team, or yeah. You created even the aortic unit? What is about and how do you use it?
That's it. We start to work together with cardiothoracic surgeons or cardiovascular surgeons in my cardiovascular institute itself, even together with cardiologists, anesthesiologists dedicated for that, even some nurses. Even we incorporated gerontologists, some internal medical, the doctors are evaluating the frailty of the patient, and for sure vascular surgeons. Just all together we discuss weekly all the aortic cases. We started in 2011 doing that, and right now we have a functional unit about aorta management from the root up to the iliac arteries. And I'm very happy about this behavior because everybody is happy, and also all the people is comfortable with that and confident about the results. Yeah.
Thanks for your answer. And my last question is actually, do you think that it's like in the abdominal aorta, extending the proximal fixation zone in the aortic arch will give us better results? I'm relating to what had happened with EVAR and fenestrated endograft, where the fenestrated endograft give you the chance to seal on a healthy sealing zone. Do you think that extending the arch treatment will be better, and even the complexity of the arch treatment will give us more chances of durability and even of feasibility?
It's a good question, but I think in general speaking, the healthy part of the aorta, when you have already an aneurysm, is quite difficult to believe about the health part, because when you have any kind of even focal, disease in the aorta, all the organ is just in danger. So for sure, you look for more healthy aspect, at least in the images. You can advise that could be healthier than other ones. If you look to land in the most proximal aspect, seems to be more, and sometimes more proximal is not so healthy, probably could be the opposite. But look for the very healthy landing zones, proximal and distally, make more sense. But also we need to be sure about the permanent fixation. That is one of the topics I'm like much more because more and more we are using more endosutures. Endosutures because if they are applying these particular devices in young people, or better say it is with a long expectancy of life, then you need to be sure about the permanent fixation. you can get a different kind of movements of the aorta or even degeneration of the aorta. But the terrific situation is when the endograft drops down. When it's fall down, that is a terrific situation. So we prefer to fix sometime when you have some kind of risk factors in order to fix with endo anchors, like a surgery, because I am vascular surgeon,
Yeah. And did you ever use endo anchors in the proximal ceiling zone of aortic arch repair?
No, yes, in the arch, but not in the zone 1.
Okay.
Yes, in the zone 3 and 4, for sure, even in zone 2, but in very few cases. Mostly in the descending thoracic aorta, we perform some fixation in the descending part, just close to the celiac trunk.
So distally?
It's just distally, because the movement in the descending thoracic aorta, when you look for the dynamics, is a little bit curious. It's just up, backwards, and also to the left side. So in the abdominal one, it's just up the front and down. So different movements in the different segments of the aorta. And we got more proximal migrations in the distal aspect of the descending thoracic tibers than proximal, down migration. So more up migrations than down migrations.
So it's better to fix the down stuff?
Yes, because we are very concerned about the proximal fixation. We look very nicely, the parallel position, wherever, in the proximal aspect, but sometimes we forget about the distal fixation and the position itself. And when you have the first CT, after 30 days, for instance, you can, get some surprises, because there are some tilts, there are some thrombus formation there, then the distal seal is not correct. So it's better to fix better and to be more a little bit, demanding in the distal aspect too.
Do you think that actually there will be a chance to treat aortic disease such as Marfan syndromes with endovascular treatment? I mean, now TEVR could be used as a bridging therapy for open repair.
Yes.
What about the aortic arch, according to you? Just because, I mean, in Marfan syndrome, usually you have an involvement of the aortic arch, and so of descending aorta.
So my general view is the open surgery should be, if it's possible, the first choice. You can think about endovascular in emergencies, for instance, like a bridge, as you mentioned before.
And it's feasible, according to you, even if it's about
yes, it is feasible. It is feasible, just as a bridge, because we need to keep in mind that the durability in those particular kind of patients, for sure, should be not so nice. So, just to cover the emergency, like an aneurysm rupture, for instance, or acute type B aortic dissection is another situation you can play with. But later on, sooner or later, you need to reintervene the patient. For open repair, if you have, two ends with previous surgical grafts, you can play nicely with endovascular, because the proximal and distal zone could be the surgical graft, and then it's safer than to deploy your endograft in the very diseased aorta.
So, and you have no risk with the trunks, or, I mean.
Oh yeah,
but there will be a dissection of the trunks, or maybe the frailty of the trunks even.
If you have a previous open surgery performed already on the patient, I'm talking about, for instance, frozen elephant trunk.
Okay.
Yeah.
Okay, so.
Or total arch replacement with instead some debranching there. And then you have a steel collar or some kind of landing zone distal to that. And distal to the aorta, you have, for instance, another thoraco-abdominal replacement or another kind of abdominal replacement with enough space in order to put your endograft there, even with fenestrated or branched devices, is safer than to perform a total, endovascular solution in a native Marfan aorta.
There will be a chance, according to you, that maybe one day endovascular treatment of the aortic arch will be the first option even in fit patients. Because, I mean, as you said during your presentation, surgery is still the gold standard, but it's very, very hard. I mean, sternotomy and extracorporeal circulation is very hard on the patient.
That's true.
I've read some literature is not so well accepted by the patient.
Yes, one is the patient perception. I totally understand that point, but also we need to think about the effectiveness one side and the durability on the other side. So the patient should be informed all the time about all the possibilities, and then you can discuss with them, with the patient, with him about the final solution for individualized situations. But as a doctors that for sure for a patient who is fit for open repair today in 2023, the first option should be recommended open repair. If the patient doesn't like to be operated on, then he can select another center probably.
But there have been some, how do you say that? Surgery now is better than once.
Yes, surgery is better right now than endovascular. Yes. As a patient making a mean test for me, I will prefer to have less aggression, less invasiveness, and a good result. But at the moment, we cannot offer the same kind of result that the open repair is offering in terms of the early results and even the late results. But everybody knows in every single center their own results. One thing is to think about scenario is to depict in a literature, but you need to transfer that particular scenarios, could be sometimes idealistic scenarios, to the reality in your own center. And also this is another important thing, you need to, if your center is not capable to do that particular, this kind of operations, you need to renounce some kind of vanity and to transfer the patient to another center. That is the key for the centralization.
What's the minimum according to you?
The minimum per year?
Cases, yeah.
Aortic arch?
Yes.
It's 30 per year.
30?
30.
Okay. 30.
Yeah.
Okay. And
in combination.
Okay.
Open, endo, even hybrid procedures. Yeah. Centralization is key for those particular complex patients. We have centralization in my country, in my county. In Catalonia, no in Spain.
And in an emergency setting, you will be more favorable to parallel graft technique or to physician modified, for example?
In emergency setting, I prefer to have off-the-shelf devices, always. To perform something in the middle of the night, just due to the fact that the emergency could be in different colors. But if you fail during the making the foramens or making the sutures, reinforcements of the snares, whatever, the reinforcements of the fenestrations or the inner branches sometimes or outer branches, is quite is a little bit dangerous or challenge. But if you don't have anything else, for sure you can do it at that. Because it's like a compassionate use. If you don't perform that solution, no other solutions are possible, and then you need to perform whatever is possible in your hands.
Okay, thank you.